Um, Hello, everyone, and welcome. My name is Danae Barkey. I'm an adult patient and the executive director of HCU Network America. And I'd like to thank you today for listening to today's Facebook live chat focused on the Homocystinuria Data Collection Program, the Oral Health Survey. We invite those who are listening in to our live recording to post your questions and comments in the chat or into Facebook. And we will work to address those as we see them. For years, it's been discussed how the low protein diet and medical formula impact patients, classical homocystinuria patients' health. The diet tends to be low in calcium, calcium-rich foods, and the medical formula is high in carbohydrates and sugar, putting patients at risk for both tooth decay, gum decay, and tartar buildup. Overall, for homocystinuria specifically, very few studies have been done. In 2012, there was a study published out of Sweden with 14 patients and had found classical homocystinuria patients had short dental roots, high narrow palates, and underbite. There's a medical word here, and I can't pronounce it. So, and there was also crowding and early eruption of teeth, probably due to the crowding. This leaves us with many areas still unknown. The oral health survey focuses on 12 different aspects, but today we will only be talking about the ones that we have experience with. Today we are sharing our experiences in that area, which may or may not have to do with homocystinuria. We just won't know until more patients enroll. To help us further understand the landscape of patients, we ask anyone who is listening with a diagnosis of any of the homocystinurias to register with homocystinuria.rare-x.org and take the oral health survey. If you have not registered, you will have to take the health and development survey first after you consent in order to unlock that. Dr. Chapman will be taking our de-identified data and pulling it in December to write in a report, which will then go into the data pool for the updated guidelines for homocystinuria. So we are really excited for today's topic, just because we know that here within the next few months, there's a potential publication to also come. So I'd like to introduce our guests for today. We have Brooklyn and Ashlee. Brooklyn, do you want to go ahead and introduce yourself?
Sure. Brooklyn, I was diagnosed at age 7 at Montana Hospital in New York City. I'm currently living in Montreal, Canada, and I am participating today so that I get know more about how this condition develops. And our doctors don't currently know, and I'm constantly hearing, we just don't know yet. We have to find out, we have to wait. So since I can't go to my doctors for information, this is where I go.
All right, Ashlee, do you want to introduce yourself and Michael?
My name is Ashlee. This is Michael. He has Cobalamin G. He was diagnosed at 5 weeks old, and he anyway, we are. I'm sorry. This is the only way to keep him quiet.
That's okay.
But we like to participate in this just so people can get treatment and answers. We can't with rare disease, they just need numbers really before they can draw bigger conclusions. So we're happy to be involved.
Yes. Well, thank you so much for both of you understanding and helping champion this cause. We definitely need more patient data to actually really understand the manifestation of homocystinuria in patients and what it looks like, either through a delayed diagnosis like Brooklyn and mine, or for Michael, who was diagnosed at birth. And just because you have a diagnosis at birth doesn't mean you get to be exempt from things. Unfortunately, we definitely see that across the disease area. So I just wanted to first kind of check in here with general oral care. The standards for oral care in the US recommend that a child have their first dentist checkout up about 3 years old. Some will get told to go in earlier if they notice things. Kind of start with a little background about me. So I was diagnosed when I was 10, but definitely had some major teeth issues going on well before then. At my first dentist appointment, we were a family that brushed all the time, breakfast, and then after dinner in the evening. Our parents did not allow us junk food. Like our junk food was like banana chips, so it was still very healthy. We had milk and all those kind of things, of course, before diagnosis, and knowing in my case I needed a low protein diet. But at that first appointment, they discovered I already had 5 cavities. And my teeth were, I'll go into deeper detail, but they were already not in really great shape. So even from a young age, I had a lot of oral hygiene issues. They also noted already at that point that I had very low enamel. So it wasn't obviously due to the low protein diet or medical formula because it hadn't been started yet. So I think in my case, some of that just already existed. My siblings did not have that same experience. So it's hard to know, is it just homocystinuria or is it me? And that's where some of this has to come through other patients as well. Brooklyn, do you know like about the first time you went to the dentist? Was it kind of just a normal routine checkup? Did they find anything? Can you tell us about, you know, your history just a little bit before we go deeper?
Yeah, no problem. My history is a little more complicated because I was born in Ukraine and I came to New York. I was 5.5. My parents focused on getting me diagnosed, so I didn't see a dentist. It wasn't a priority, really. I didn't want to brush my teeth multiple times a day till much later. And I think my first dentist, I was maybe 7 or 8. And he made me so scared of going to dentist because he couldn't numb me properly. He bounced back and forth between patients. It was just a very poor experience. I found out everything that I know about my own oral health much later in life. Probably 1, because I was so scared of dentists, and 2, because someone else actually took a closer look when I gave them a chance.
Yeah.
But me too. I had my poor enamel, but it's not really clear if that's genetic or if it's HCU related.
Yeah.
So
yeah, and we'll dive into all the additional findings that kind of have come along for all of us. Ashlee, I know Michael is still really young. I mean, he's not. Is he 3? Or is
No, he'll be 3 in April.
Okay, I was like, I would get him and one of our other Cobalamin G patients. Like, I know they're close in age, but they're not that close in age. So I was like, is he the same age? Okay, and so, you know, how old was Michael when you noticed, you know, some of the initial dental things? Are they just kind of popping up now, or?
Before he was diagnosed, he was having feeding difficulties, which is pretty typical with these disorders. But before they understood, you know, that he had an actual problem, they thought it was, what's the word? Like a physical problem with sucking, because he had kind of an overbite. So they thought it might be related to that. So that's something I noticed when he was, you know, 3 or 4 weeks old. And then when his teeth started to come in, the one I sent you a picture of, we didn't know if it was cracked at first or if it was I had thought all along it was just 2 teeth that got crowded together, because one, if you look at it from the bottom, one is turned.
Yeah, like, is that the one with the front on one or the x-ray one? Because I can actually pop that up here first.
The front on one. And it wasn't until relatively recently. I mean, we always knew he had a funny looking tooth, but we didn't really think much about it. Yeah, if you see the section close to his front tooth, see how that tooth is turned? It's almost sideways, and if you look at it. So I thought it was just two teeth crammed together and it pushed it sideways. And it wasn't until months later I was like, wait a second, he's got an extra tooth on this side that he doesn't have on the other side.
Yeah. It's so interesting looking at that. And I know we're going to talk more about that because it's funny kind of looking at some of these things and hearing about them because it's crazy the amount of different things that can happen to your mouth. We think mouths are structured pretty much the same, but when we start having these differences, it's amazing all the things that can happen. And I definitely had some pretty interesting teeth formation here. So I'm going to stop the share just so we can go back to our faces here. And so it's interesting though that it's that early on, that.
Yeah. And we happened to, I think we had delayed a little bit going to his first dental appointment because of COVID.
Mm-hmm.
And then we took him to his first dental appointment a little after he turned 2, or maybe close to 2.5. And they didn't do any x-rays then. They just did a cleaning. And then the next week he got that tooth injury. So we had to go in and get x-rays. So
I can't imagine trying to do, like, it's already uncomfortable as an adult, in my opinion, getting like a mouth x-ray, just because I don't know if it's the same procedure for little kids, but like kind of sticking that essentially a slide in your mouth and trying to bite down. I don't know, it makes me gag typically every single time. And so
luckily he has a natural tendency to bite things in general. So, like most kids, if you try to put your finger in their mouth, they're going to bite you. So at least it was that,
That's, I guess that's a good thing. That is kind of like, it definitely simplifies things here a little bit. So the first area that we're going to explore here is, I'm breaking down the sections and kind of lumping some of them together here for our audience. So the first area is gingivitis and gum disease. And just for other people, a little bit of background here. When we're talking about gingivitis, we talk about early gum disease. So it hasn't actually completely developed into gum disease. That can be inflamed gums, gingivital inflammation, and red and swollen gums. And then gum disease is the step after that, when you actually start, it's the loss of the tissue around the tooth. There's a much more complicated name for this too, but I'm not even going to go there. But I know for myself, I've always struggled. And if I am not really on top of brushing, especially after formula, my gums get so inflamed. And it's certain foods too, popcorn seeds, they think they're just awful things anyways. So they're definitely go through periods. And so then I tend to like crack down, and then it's just like, oh, it's getting better. And I'm like, okay, and then you relax, and then it's like starts to get worse. So moral of the story for me is stay on top of it and you won't have these issues. But I don't know, life gets crazy, and it's sometimes easy to slack in self-care, even very basic self-care. But definitely has had an impact. It's extremely uncomfortable though. It makes you not want to eat anything, just because the tenderness. Brooklyn, you had noted in your our pre-conversation survey about gum disease. When did it first start to become apparent to you or to a dentist or oral hygienist that the issues that you were having?
I noticed it myself looking in the mirror after I brushed. It was red, but I just thought it was because I was brushing too hard that my gums were red. But eventually I saw the right kind of dentist who said that no, they are inflamed, 1, and 2, because they're so inflamed. I also don't know that this term, there's too much space between the gum and the teeth. And it was about double. He gave me in terms of millimeters, and he said it was about double what it should be. So yeah, it was a very large number. I can't say that it really impacted me other than just the way it looked, but because I didn't know any better, I thought that was normal. And I don't take a close look at other people's mouths to be able to say, well, yours isn't that red.
Yeah. Well, and that's the other thing. I feel like oral, like mouths differ a lot, especially in different countries. Like you look at Americans are obsessed with teeth. Like we are so obsessed. There's this whole David Sedaris, like one of his little talks about going to, it wasn't a dentist, but you know, one of the oral hygiene people in, I think it was France. And it's just interesting to me. So, you know, what is normal, I think also really depends on where you are situated in the globe. However, you know, in terms of like gum disease and gingivitis, I think that's going to be recognized regardless of where you're at, just because no one wants their teeth falling out. And so it's, yeah. So did they do anything to lessen the chance of it getting worse, or what was their approach in treatment, or what did they say?
I was given a rinse and told that I have to just floss more. So I finally got into the habit of flossing more, and that rinse helped. And I only need to do the rinse for 7 days. In fact, if I was to do it anymore, it would have started to undo some of the changes that helped. So they're less red now, and there's less space, but it's always, the gingivitis is always going to be there. Just because it was so severe at one point. I don't know how I didn't notice it, because I think I'm just so used to eating foods that have acidity that I must have numbed myself. Like if you would eat spicy food, you get used to it after a while.
Yeah. No, that makes sense. It makes a lot of sense. And the thing is too, is like you adjust to what is normal to you. So like you said, like you didn't know any difference because it's always been this way. So it takes someone who's more objective to come in and say, hey, this isn't normal. And a dentist or, you know, someone in that line of work makes sense. So one of the other areas, they have such fun, complicated names for all these things. So this was a big learning curve for me. There's bruxism, malocclusion, and overbites. And, you know, so how did you say it, Brooklyn?
Bruxism.
Okay, thank you. I was like,
yeah.
I was like, they need an enunciation key in Rare X to go with each of these things. And so bruxism is it's characterized by the grinding of teeth, including the clenching of jaw. Malocclusion, I looked this one up just because I was like, well, what is this? Because it said dental malocclusion refers to abnormality of the alignment of teeth, resulting in crowding of the teeth or an abnormal bite pattern. So like there's actually 3 phases. There's like the normal, like slight overbite, then there's like the overbite, and then there's the underbite. So there's 3 different categories. And I think probably a lot of people have some kind of like slight overbite. Just you look at how many people have had braces in their life. And so, I mean, there's probably some level of normalcy to here. So the first area we were going to go into is the bruxism. I'm still not pronouncing that right. Brooklyn, do you want to talk a little bit about how that's impacted you, and then the other diagnosis that went along with that for you?
Sure. I didn't learn about the bruxism until I had a dentist specialized in the TMJ, which is a temporomandibular joint. It's the joint responsible for us to be able to eat, chew, yawn, talk.
It's like, I call it the hinge. It's like,
yes, it's this and this connected. Yeah. So what happens is, instead of it going smoothly like an arch, it pushes. So if in a patient with TMJ, they're able to open their mouth, and then the dentist says relax, and it click open, and the clicking sound is the what anybody that hears clicking would know that there's something off, but dentists will call it the TMJ issue always. Bruxism is related because those who have TMJ are more likely to grind their teeth, and particularly at night. So I have to wear a night guard, and my dentist even says that I had a cleaning. He just looks and he could see the wear and tear on my teeth, especially in the back. So even if I don't notice it, even if I don't wake up with my jaw heavy and tired and stiff, it's still evident on my teeth. That's something that could be reversed.
Yeah. So it was interesting because after you mentioned that, I did a little bit of Googling. What would I do without Google? Don't feel like I could have actually any of these conversations very well. And it was interesting because like I am definitely a teeth grinder, and I didn't know what TMJ was until you had mentioned it. And I was like, I probably need to go see a better dentist. Just kind of got passed off. It took whoever my childhood dentist referred us to when he retired, and definitely have very clear symptomology of TMJ. And it is so apparent. And I just remember having like my cousin stick her finger in there and be like, feel this. And she's like, I don't need to feel it. I can hear it. And she just, it would gross her out. So, you ever want to just irritate someone to irritate them, you do something gross when you're younger. Probably not the nicest thing to do. But it's interesting because they correlated it also to like the bruxism to higher levels of stress and anxiety, which makes sense because, stress and anxiety manifests throughout your entire body. And so, especially teeth grinding. And so,
yeah, and there's also one more thing. With TMJ, we have because we're grinding our teeth. The bone could also be also it could also have a lot of bone loss quicker. So if you need to get injections, they recommend not injecting into that joint at all.
and I wonder if that also goes back to the whole, we know in homocystinuria patients that bone density tends to be an issue as well. There's so many things that happen to the bones, cartilage, bones, cartilage. I know I'm forgetting another piece there, in the joints. And so I wonder if this is just, possibly another manifestation. You think about your bones and your teeth, and they all have in your nails, and they all have kind of similar makeup. So in my mind, it just like how much of this is all like correlated together. Maybe it's not, but
yeah, that's probably why it's so important to do this kind of information taking, because I don't know if you found it in your research, but because the TMJ is so close to the ear, a lot of patients also experience vertigo.
yes.
So they might not realize that their vertigo has anything to do with their mouth.
Yeah, that's really interesting. I would have never thought about that. And I definitely have periods where I get really bad vertigo. Like I'm just going to live in my chair because it's too dangerous to get up. And I work in my basement, so our floors are pretty much, and it's just linoleum covered cement. It's not safe when you're like that. Even sometimes sitting up is too much. But that's really interesting. I would have never, but it makes sense when you go to an ear specialist. It's ear, nose, and throat. Well, your throat is connected to your head, which is your mouth too. So and your mouth is in the middle, right between your nose. And so
ENT specialists can often actually diagnose TMJ. So you're right. It's all very much connected.
Yeah, that's really interesting. When I was reaching out to community members, one of the moms whose child has severe MTHFR, also mentioned that her son has a diagnosis of bruxism. And what I thought was interesting about this is that the bruxism is secondary because of a brain injury that is due to severe MTHFR diagnosis, just because they have more neurological complications in severe MTHFR. So I think that's an important thing to be aware of, just because, you know, if you've experienced any of the neurological impact of homocystinuria, I mean, again, it all makes sense. It's also interconnected, such a fine-tuned system that, you know, I think when we're looking at all these pieces, it's important to kind of know how they fit together. So we're going to move into the malocclusion part, which I'm still probably pronouncing wrong, which is that the alignment issues, and also the tooth malpositioning. So I think most people know what an overbite or an underbite are. So I don't think I really need to go into detail about that. But Ashlee, were Michael's issues with, he has an underbite, overbite? Sorry, I'm trying. My notes are sketchy. You're on mute too.
I have, he has an overbite.
Okay. Can you talk about, you know, when that, I don't know if you mentioned it earlier, was it apparent like as an infant, or how far along into things did it become apparent?
It was apparent when he was a newborn. One of the things he's always done, and still you saw him earlier doing, to self-soothe, is he's always chewed on fabrics and blankets.
Mm-hmm.
Excuse me. But that just makes it worse. And now that he's got all of his teeth, you can kind of see them being pushed out even more.
Mm-hmm.
And the dentist talked about trying to limit that, but at some point we have to consider, you know, his quality of life, and if that's what comforts him, it's going to be rough to take that away. And is it really worth it right now?
Yeah.
And he, and the problem too is I've noticed in the past, like if I put him in his crib without a blanket, he'll pull up the sheets and chew on those. Like he'll find a way.
Yeah.
So that's just made it progressively worse.
Yeah. And I know it's asked you this, and that, you know, I know this doesn't go along directly to the teeth thing, but you know, so many of these things relate to other areas. And I think about myself as a child, and I was a very anxious person. I also had a lot of sensory issues. Does Michael have any sensory issues? Like,
not really, not that we've noticed. When he was younger, I remember thinking about just like little quirky things he did, wondering if you know, he might, but he doesn't seem too sensitive to things like that. I just, for the reason, he's always been a biter.
Yeah. Well, you would much rather him biting on a blanket than like an actual person or someone else. So
he bites people too, but we encourage the blanket.
Yes. Has it, I think you said that it has gotten worse, but it's, you know, again, that quality of life thing I think is really important, is, you know, that you do have to have a way to self-soothe. You have to have a way to cope with whatever it is that's the trigger.
Yeah, and since
that
he
might be teething.
Yeah, and he actually, when he was younger, he would prefer to chew on a blanket after he got his shots than to have a bottle or something. Like that was the most soothing thing for him, was the chewing and sucking. But now that I think about it, I remember we've had issues with him eating. Because he's kind of a picky eater, and they were wondering if maybe he might have some oral sensory issues. But
across the board, it seems like there's, I can't say across the board, but it seems like quite a few patients in general have like sensory issues, I being one of them. I was a pencil chewer. Like that was until someone really pointed out how disgusting that was. That I'm a nail biter. I have terrible habits. No one should look to me as an example in those areas. And so definitely has an impact. Brooklyn, sorry, I'm going back here. So you overbite, underbite? Sorry, my note, I don't have it clear for myself.
No, I don't think I have either.
Oh, okay, sorry. Malocclusion, or is that?
Well, yeah, my teeth are misaligned.
Okay. Okay. Oh, and I think that was going into the abnormality of the, like, go ahead. Go ahead. Sure.
So, like my upper teeth go in one direction, my lower teeth go in the other direction.
Yeah.
It's not severe. Like, I mean, it would be okay if I had to get braces, but as an adult, getting braces is that much more difficult.
Mhm.
And they didn't realize the problem when I was growing up.
Yeah.
So at this point, like there's a lot more work. I am also missing a tooth, a bottom left quadrant, which they now think is contributed to my teeth shifting.
Mhm.
Well, I'm lucky that they didn't shift into down, like
Yeah.
away from the gums, but they did shift so that they're misaligned. But I mean, is it contributor to the TMJ? It can be. They just don't know. There's a lot of information that they're assuming, because I've had TMJ issues that I've noticed since I was maybe since I was diagnosed, or maybe even before.
Yeah.
But I didn't know what it was until later on. I just know the clicking was tiring to chew.
Yeah.
You know, and later on, when in my 20s, my left side of the face swelled. So I needed to find a specialist to help me align my left and right, so I don't look so uneven.
Mm-hmm. Yeah. No, that also would probably be not probably, that I'm sure it was extremely uncomfortable.
Yeah, try sleeping that way. So
yeah, I think that's the hardest thing, is like anything when you have it going on in your head. Like, I didn't have ear problems until I was an adult, and that was probably the most miserable experience. And then I was like, oh, I understand way more now why children are so miserable. And it's so, it's awful. I know for myself, I had a horrible overbite. I had 4 years of braces, so a lot of things kind of came to a front for myself in preparation for getting braces. I had braces all 4 years of high school. It's like the worst time. I'm glad now kids start braces much earlier. And I think as a result, they don't have to wear them as long. But sorry, I'm trying to look at my own notes for myself here. I should know. But because of the overbite, I also have a narrow palate, which is common with homocystinuria. It affects your speech, but it also creates overcrowding of teeth. And so when I went to go have braces, they had to remove a lot of teeth. I think I had 5 teeth removed, plus at that point the wisdom teeth they could see because it was my adult teeth, so they went in and removed them. But it was a much harder process because one of them was impacted, and so it was extremely painful. And even with having all those teeth removed, I actually didn't, all my adult teeth never actually came in. Like they weren't there to begin with in x-rays. And so I'm glad. I would have had much worse crowding issues. And it just made for some really funky looking teeth. But it was interesting because when I was looking up other things that narrow palate of the mouth can contribute to, it can also contribute to tongue ties and sleep apnea and speech variances. And I spent kindergarten and first grade in speech therapy. Just remember being hauled off into a little tiny closet. Like, I think every kid who went to any kind of special therapy in the 90s, it was always in a closet at the end of a hall, and it was dark. It was never like a fun experience, but I remember it though, because she made it very fun. There was a lot of games, and I felt like I was getting to do something different and special because of it. But it was all to promote language. And so it's like, oh, now you can start making connections better because of it. I was the only one in my family who had speech therapy, other than my brother, who also has homocystinuria. So the other area, we're on our almost last page of things here, is the abnormalities in teeth, dental root and dental pulp. And so my area that I had here was the malformed teeth and abnormality of baby teeth. So this includes misshapen teeth, abnormality in the shape of teeth, or a deformity of the teeth. And Ashlee had shared with us Michael's, that one picture. So he has additional teeth also coming in. Is that what you? I was trying to think back to the email, Ashlee, and I apologize.
They when they did the x-ray for the injury, because at our first dental appointment, they said when this happens, sometimes you can just have normal teeth behind it. Sometimes you could have no teeth behind it. Sometimes you get extra teeth. So we didn't really know. But they said, so the double tooth is the one kind of in the middle, right there where your mouth is.
Yeah.
And it looks like behind it are two teeth coming in, but she said the buds hadn't fused yet. She said they could possibly fuse in the future, but so far there is an extra tooth, and hopefully they'll come through and they'll pull one, and then the other one can come through. But then if they fuse, then that's a different story.
Yeah. I'm going to stop that share. I appreciate having that, because I think it makes it easier to visualize, especially like I could visualize it just because of all my fun teeth issues. But I know for others, it's sometimes just easier to have those pictures. So thank you for sharing those. Has that impacted, do you think, any of his any other parts of his development, like his, if it's feeding or language development, or do you think it's just?
I don't think so, because it's so small, and because it fused, it's fused and it's turned, so it's about this width of a normal tooth, And I think his speech issues are just the apraxia that pretty much all Cobalamin G kids have,
Yeah.
Because he talks a lot, just not in English. But yeah, I haven't noticed it with the feeding either. I don't think it really bothers him. We were kind of, when he got his tooth injury, we thought it was that tooth, and we were kind of happy because we figured if you got to lose one, we'd rather it be the one that you got an extra one there anyway, But unfortunately, it ended up being the front tooth.
Yeah, no, I completely I understand that. So when I had my baby teeth were some of the most deformed looking teeth I have honestly ever seen. So your teeth usually come in like this across, and a lot of them were more like this. And so that turning that you were talking about with Michael, I was like, oh, that was a lot of my teeth. And they weren't always necessarily like this. Some of them were more like a 45-degree turn rather than like a complete 90-degree. And it was just, I don't know. It created a lot of ridicule when I was younger. And the other thing is, like, my canine teeth, the only way I can describe it is like you think about like a cliffside and how jagged it is. And so there was like these complete divots in my teeth. And I think that was because of the wearing of the enamel. There just was like no protection of the tooth. And the canine teeth were like super, super sharp. They were like little dagger vampire teeth. And so that part people thought was cool. My brother specifically, because you know, sharp pointy things are cool. But my teeth created a lot of harassment because they were so I don't know. I think that probably also is what also contributed to the cavity issue though too, is that, you know, if your teeth are turned in such a way, your toothbrush is not able to maximize its ability, leaving stuff left behind. And most kids aren't great at brushing their teeth. I'm sure I wasn't any better than most kids. So it definitely created a lot of issues. So the last areas here were abnormality of the dental root. So what is interesting is that most in the literature that there was is that most homocysts, like going back to that, you know, whole 14 patient study in Sweden, the patients all had short roots. And Brooklyn, I'm going to call on you here in a second, because I know that's not your experience at all, but then there's also abnormality of dental pulp, and that is the soft tissue within the pulp, within the cavity, located in the center of the tooth, which I still am having a hard time to like wrap my head around that. So maybe you can talk about both of those things, like when it was discovered and how symptoms. So I'll let you kind of go at it here.
Yeah, so for me, the reason it turned out that I was so scared of going to the dentist because they couldn't numb me properly. Why? Because they're numbing me like for the average person. My roots are much longer, and because of that, not all dentists know how far to go, and two, how much to inject at each spot. So if you have a canine tooth, you have to inject multiple times because there are multiple roots. They further confirmed this when I had to have 2 root canals redone by an endodontist, and he's the one that I'm very lucky with, because he spoke English, he was patient, and he took his time. And during one of the procedures, he said to me, "You typically see 3, maximum 4 roots in the big teeth." I had a 5th root that was attached to one of my roots. This is why it was missed. So when the root canal was done, it wasn't a full done. It wasn't dead, actually, because of that. The root was a baby root. It didn't open like properly, so he had to open it. He had to fill it in order to be able to finish his job. But yeah, that's another thing that I would say probably more and more HC or homocystinuria patients need to be wary of, having to redo teeth. I know I've had at least half of my teeth had a root canal in them. And my very back tooth, speaking of weirdly shaped teeth, it's a good 90 degrees. So the long roots can't be touched unless I have it removed surgically, because right now it's more like a stub. It is more the roots are longer than the tooth is bigger.
Oh, wow.
Yeah,
that's a long.
Does that make sense?
Yes, that makes sense.
So I don't know, but I also know that my younger sister she doesn't have homocystinuria or anything like that, but she has very long roots. So it could be just genetics that play a role in this. I don't know.
Mhm.
But
No one wants to have root canals done to begin with, let alone like getting them done twice in the same tooth. Like that just sounds absolutely awful. Like that's like that's horrible. My sister had to have a root canal. I did not, and I have to say I'm so thankful, but she was absolutely miserable for like it was a good 2 weeks because it was just so tender. And it's just they're expensive here in the United States too. So
and they have to leave it open. If when you redo the procedure, they have to leave it open. They'll put a temporary cap on, but they won't fill it properly as if they were finished. So it would take 2 or 3 sessions.
Mm-hmm.
If it's one of the bigger teeth.
Yeah.
It's expensive.
Yeah. So I have some takeaway things from a couple of other publications that were for larger inborn errors in metabolism. But before I go there, is there any additional things, Brooklyn or Ashlee, that you don't think we touched on regarding, oral health, development of the mouth and whatnot that you think should be touched on or that we missed?
I just have a question, and I don't know I haven't had a whole lot of teeth problems myself, so it's not something I really had to research much. But like in your situation, would veneers be something that is an option? Would that help at all, or is that just an aesthetic thing? I've heard of people with like certain tooth diseases getting them, and it sounded like it was more of a protective thing, but I don't know enough about it. Have you ever looked into that?
I haven't. Brooklyn, have you?
I was told that it would not be an option.
Yeah.
I was just thinking with the enamel, like if it gets worn down, if that protection or something. I know they're very expensive, but I just don't know enough about them. I didn't know if they were purely aesthetic or if they have.
I think it also has to do with like, here in the US, a lot of times they won't mention things until things get bad enough. So it probably depends on how far down. I know my mother-in-law has some veneers, but she also has way worse issues with her teeth than I have ever had. And so for her, it made a lot of sense. She's also older. So, and we know the older we get, the harder it is to fight off infection. So it was, I think, more of a preventative measure than anything. And so there are some things, though, that can be done, actually. And so this is in the takeaway stuff, actually, but I think that's a good question. So one of the things they started doing to my teeth, actually, is there is, I don't know what the proper term is, but there's a treatment, and it's kind of like, to me, it looks like nail polish, but I know that's not what it is, but it's an enamel polish they can paint onto your teeth. There's also fluoride treatments that they can do, but there's an enamel coating they can help put on your teeth to protect it. And it usually lasts, I think it's like 3 to like a few years. And that seems to I haven't had cavities in a really long time. It's also probably because I'm an adult and I know how to properly brush my teeth. And I don't eat as much stuff as I used to. That was like straight sugar. But there are some things. So there is a couple of things. So there was a podcast that the Journal of Inherited Metabolic Disease, they do a podcast and they focus on different publications. And they interviewed one of the authors that wrote a 2020 case report on the impact of dietary interventions in inborn errors in the metabolism. So dietary intervention being low protein diet, medical formula, or even in the case of some patients, tube feedings, because not everyone eats orally with an inborn error. In pediatric dentistry, the review of the literature and the case series, they suggested, so this were some of the recommendations that came out of that. that a diagnosis of an inherited, I'm drawing a complete blank, inherited metabolic disorder should prompt the clinician to make a timely referral to a pediatric dental service for an initial assessment and implementation of robust preventative dental regime. And this essentially just, I think this happens in other parts of pediatric care with different conditions. And it's just, so you have that baseline assessment, and then you have that connection if you need to go back to it. But it's better to start off early than having to go back and make up for lost time. And I mean, we all know if we can get ahead of things, it's less likely to become a bigger problem down the road. The reason why they also recommended this is because, as with any infection, an oral infection can lead to poor oral hygiene. Because if you have an infected tooth, you're not going to probably want to brush it because it hurts, or you're not going to want to take your formula because it's acidic. And so, which then increases the chance for elevated levels and metabolic crisis. So good oral hygiene, is more than just your oral hygiene. It's your overall health. And then for those on a low protein diet or formula, they should be immediately rinsing their mouth after consumption, just because it is really corrosive and acidic, and it breaks down that protective enamel that is naturally on your teeth. And then all patients should brush their teeth at least twice a day. I think that just kind of goes for the general population and in general. And then they mentioned also a fluoride varnish application and fissure. This is what they were talking about with the enamel. Fissure sealant provision should be considered. I just thought that was much more complicated way of putting things. But the only other guideline I think that's important for patients and caregivers to be aware of, and it's not necessarily even just to do with dental care, but with all homocystinuria, if you have to be put under nitrous oxide, should be avoided. So a lot of times that's kind of like the natural go-to thing is nitrous oxide for oral procedures, and they recommend against them. Obviously, there's some things that have to be done, but it's important to talk to your geneticist and your care team when you are preparing for any surgery, because there's some other things that should be taken into consideration, like patients shouldn't really be fasting for extended periods of time. So there's more than just the nitrous oxide part that should be considered.
That was part of the reason I delayed getting Michael in as well. Just our dentist here, part of the change with the COVID procedures was they were taking kids back without their parents, and I just did not trust them at all to take a 2-year-old who can't speak.
Yeah,
he freaks out. They put the gas on him. I've seen it enough in hospitals where people miss allergy bans and they don't even have that in an office. I was just like,
yeah,
nope, not worth it.
I just think about, like, Dana is 4. She doesn't have any health things, but I remember her first dentist appointment and it was awful. And I can't imagine trying to be the dentist dealing with that without me there, because it was like, it really took the dentist, the tech, and myself to get her to a comfortable point so they could, quote unquote, count her teeth, just so they could look at them. She wouldn't even open her mouth. And so this stranger with a mask covering their face, like, that's really intimidating to a child. I mean, and the dentist is not, no one is known. I mean, I don't know any dentist that, has this phenomenal reputation for, like, I hit it off with every 3-year-old upon the first appointment. Like, sorry, that's not how most 3-year-olds function. You get stranger danger, you get them right in your face. It's just not typically something they're too keen on. And even as adults, most of us don't really love going to the dentist, but we know it's an important thing to do. So, anything else before we end here?
Yeah.
Oh,
yeah. So I just thought I wanted to point out a couple of things.
Yeah.
Maybe because it's so rare. So the first thing is, if you as a patient or your child has TMJ or you suspect it, find a TMJ dentist. Because a regular dentist will not be able to know what they're looking for, or have maybe even ever heard of it. And in my situation, I got very lucky. My dentist knows, my TMJ dentist is very skilled with TMJ, was able to send me to a TMJ physio so that my face evened out, and even understands my diet. That he understands homocystinuria.
Yeah.
And a lot of regular doctors that I deal with, adult patients, have never heard of homocystinuria, let alone a dentist. So it's very important to find the right dentist, even if it's not maybe the family dentist that you have to go to.
Yeah, that's actually, I think you make a good point, because in that publication that I was talking about that was written in 2020, there are some dentists who don't really understand the importance of like the low protein diet or formula. And I think about this even with like, the Cobalamin disorders and severe MTHFR, where the kids are taking cysteine, and what do we naturally put that in? It's typically like some kind of juice, which most dentists are going to be like, oh, you shouldn't, kids shouldn't be drinking juice. They don't need it. But in order to get down cysteine, I think as parents, we would do whatever we need to get our kids to take it, because it's not a very great taste. Even as an adult, I would never take it with just water. I've had to do that for surgeries, and it's just like, oh, it's worse than formula, to be quite honest. And so making sure they understand, like, homocystinuria does have an impact. We know it has an effect on bone. So it's safe to probably make the assumption that it does affect your teeth, and that, our treatment for any of the homocystinuria, they're not optional, that we have to do these things regardless of how the dentist may feel. It is what it is. And so I think that's a really good point, is, it's our job as patients and caregivers to educate those. But I think you made a really good point, though, about, with the TMJ stuff, like finding a dentist who's actually familiar if you have some of these other additional issues, just so that way they can be more on the lookout for things and help you actually treat them properly. You had also mentioned, if you can't find, a TMJ dentist, you said an ear, nose, and throat doctor might be able to help too.
Not, I can't say all of them. Mine never mentioned it, but the ones who are trained more recently, mine is probably in his 80s at this point. But someone within the last 40, 50 years would be able to know, because they'll do an actual inspection of everything involved. So yeah. And if they do say they have TMJ, more like most likely you do, because you'll notice it yourself.
Yeah.
Clicking, does your mouth get tired just by chewing? If you have also, my TMJ physiotherapist told me something very important: never chew gum.
Never chew gum,
because it's empty chewing, and it forces more.
It would wear out
for no reason.
Yeah, that makes sense. That makes a lot of sense, actually. Especially if it's wearing away at what cartilage and bone is there. I mean, you definitely don't want to do anything to create more damage to an already problem area. And that makes complete sense. Anything else?
That's all I've got so far, but we're pretty early in the game.
Yeah,
well,
exactly.
I appreciate you both coming on. Thank you, Ashlee, and thank you, Brooklyn, for sharing your experiences. And just a reminder to those, Dr. Kimberly Chapman here in December will be doing a data poll from the RareX. Dr. Chapman, she is one of the HCU Network America medical advisors. She also sits on the committee that writes the guidelines for diagnosis and management for homocystinuria. So she's put out an appeal, and I am putting out an additional appeal on her behalf that this month that you do, if you have not taken the time, please enroll in RareX, homocystinuria.rare-x.org. Please go ahead and enroll. If you have enrolled, please make sure you've completed the health and development survey, which will then unlock other additional surveys about different areas of the body. Oral health survey is the one that she'll be specifically focusing on. And I'm really excited because the current guidelines don't mention anything for oral health. So the more patients that we get in there and understand, the more likely we can have better guidelines that not just help us as patients, but help clinicians foster better care for all patients. So we appreciate all those who, we have 42 patients currently enrolled in the RareX registry for homocystinuria. So we really do appreciate those who have enrolled and started to complete the surveys. Just please continue to go back and update and check for new surveys as well. So thank you, Ashlee and Brooklyn, for your time today, and appreciate it. Thank you.
Have a good one. Keep in touch. Bye.
Bye.